Hello, I'm Dr. Maria Azizian, a board-certified general surgeon and IFM-certified functional medicine physician. Usually on this channel, we talk about functional and conventional medicine, medical research, skin health, etc. But today, I would like to focus on the practice or the art of medicine. And I would like to discuss something that we all have gotten used to and something that is so ubiquitous for all of us as consumers of medical care, and it is your average 15-minute appointment. And I have to admit that this is one of my biggest pet peeves, and not only mine, it is shared by many of patients and many of my colleagues. And I think that this is one of the important components that contributes to patient dissatisfaction and to doctors' burnout. And this video was in a way triggered by one of my colleagues who was telling me about this very interesting and complex patient that she was seeing, and that patient had lots of labs, had lots of questions, there were lots of issues. And she said, but 15 minutes is not enough. And she said it in a very exacerbated way that really resonated with me. So I would like to talk about that because I do think that it affects our healthcare in more ways than we can think. So what is 15-minute appointment? It's 4 patients in an hour, but in some practices, especially in fields like primary care and dermatology, the practitioner, the doctor, the PA, or whoever is administering medical care would be asked to see up to 6 patients in an hour. Now, look at it from the human standpoint. Is that normal to really listen, connect, and give a meaningful advice to somebody on any topic if you're seeing 6 patients in an hour? Well, so let's talk how it impacts the patient and what are the components of this visit. Because I would like to show you how it looks from the doctor's standpoint, because all of us know how it looks from the patient standpoint. But also, yes, I would like to comment on how the patient feels as well, because I've been a patient, I've been a receiver, and I know how it feels. So one of the biggest things for us to understand that this appointment or any encounter between a doctor and the patient, and when I say doctor, I mean a medical professional, and the patient, it's really about healing. It has to be a healing appointment. And when I say healing, it doesn't have to be all words, because big portion of our communication is nonverbal. So even non-verbally, we have to make the patient feel comfortable and safe. And part of that, of course, is not being rushed or rushing the patient and just keep going and creating this nervous energy. And that, of course, is one of the most unpleasant part about just being in medical profession as a doctor, where you constantly have to be a creator of that nervous energy because you have to rush the patient. And where is the healing component? It really diminishes significantly. Of course, giving a good advice, being empathetic, and listening to the patient, that does help a lot. However, again, this nonverbal component is very important, and it's important from the start. So how do I stratify patients depending on how they behave during the initial appointment? First of all, I'd say that most patients are qualified as nervous patients. They're nervous during their medical visit. And that's normal, because if you think about it, that one of our prime instincts, it's an instinct of survival. So if you're in the medical office, you may hear something that may affect your survival. And that's very primal. So that's why people are so nervous. It just plainly makes sense. And many people, including many doctors, actually have white coat syndrome when they are patients. And that's totally normal. And people like that, they're all over the place because they are so nervous, they don't know sometimes how to start, or they forget half of what they were going to say. It's good when you actually bring the list with you that really grounds you, and that's a very good practice, I have to say. So with these types of patients, what I noticed, in addition to giving them certain space, that space could also be given verbally as well through small talk. Small talk, like old-fashioned, when you would see your doctor, talk about weather for 15 minutes before you got to the actual visit. That was old times, I think, before our times when the doctors did home visits. This actually plays a big role. And when I say small talk, it doesn't have to be 15 minutes, the whole duration of the appointment, but at least a few minutes of talking about the weather, or what town are you from? Oh, I like your hat, or something like that. Something genuine, something real, some kind of a connection that's, even though it's not meaningful verbally, it's very meaningful in terms of communication and establishing a rapport with the patient. So I find that extremely helpful. And of course, that does take time. The other group of patients, which we now see more and more, are adults with disordered thinking patterns. And a lot of them have the diagnosis of ADHD. And I have a video about adult ADHD, which I'm going to put right there. And this really is it's a shame, because you have a capable adult who could be in their 30s, and they cannot really explain their symptoms. They cannot provide a coherent story. And you know that this poor person probably has some issues, such as toxin exposure, such as poor diet, such as other diseases that contributed to this lack of mental clarity, and many other things. Often these type of patients, they have PTSD. So there are explanations for that. So again, and more about that in my video. And in the same note, there are elderly patients, and elderly patients could be different. Some of them could be very bright and very on point. But a lot of elderly patients have suffered from strokes and have some neurological conditions, such as, for example, early Alzheimer's and memory issues, and that does affect communication. So you can have somebody who, this elderly person who tries to recount something. Let's say if the doctor asks, when did your rash start? And the person would say, well, in 1955, no, 1956, I had these 3 dots, and I went and the doctor said, oh, wow. And they gave me some pills. And then it happened again. Oh, no, at that time I broke my leg. I was in a cast. And then I had to be hospitalized. And also my sister uh, actually had something going on too. I don't remember, but I think that she needed an appendectomy. And at this time, do you understand where it's going? It's becoming a tangential process where a patient is kind of like losing the thread of the conversation. And on that note, by the way, sometimes people like medical students or residents ask me, like, is it okay to interrupt the patient? In general, interrupting anybody is considered rude. However, in the medical settings, I do think that gently redirecting the patient is appropriate. Again, being very gentle and very respectful about that, because otherwise even 2-hour appointment will not be enough. Because you really need to understand what patient is talking about. So we talked about nervous people, we talk about people with disorganized thought process due to a variety of conditions. And also, honestly, we also have people who are naturally slow speakers, people who actually weigh each word because they want to make it meaningful, and they just go very slowly. And all of these people, they deserve respect, they deserve attention, and they deserve a good medical care. From my standpoint, what am I supposed to do? What is my agenda during any medical visit? But especially if it's a new problem or a new patient with all new problems, or established patient with a new problem, for me, it's to listen to the patient, examine the patient, diagnose the issue, explain it in the patient's language, meaning that avoid medicalese and jargon. Then, of course, listen to patients' questions and answer patients' questions, and then come up with the plan. And the plan could be just reassurance, could be counseling, could be very easy, or and it could be prescribing medications or ordering images, labs, X-rays, CT scans, etc. And finally, two most hated things: documentation and billing. And all of the components of the visit, except for the last two, have to be done when patient is there. And of course, I'm not going to get started about documentation and billing, because being one of another causes of doctor burnout. So maybe that's for another video. So, but these have to be done. And the core of this communication, when patient comes with a new issue, are these questions. When did this start first? When was the last time you have it? How frequently do you have it? Do you have it today? What are the symptoms? Because patients say, well, I have a headache. What kind of a headache? Is it a throbbing headache, burning, pulsating, tension headache? Where is it? What triggers your headache? There's so many questions that could be asked. Honestly, it's extremely interesting. You're getting to know another human being, but you have to ask the questions. Then you have to ask them, well, are your symptoms getting better or worse? Or what have you done about this? What medications have you taken? What modalities have you done? Like, for example, somebody would say I had physical therapy for whatever condition or acupuncture, etc. You need to know what was done, and it all takes time. Of course, you could be one of those robot doctors or one of these 1-minute doctor, and the patient says, I have a cough, and you say, well, here's your Z-Pack. And that's why medicine is failing now, because of this. Those shortcuts won't do. That doesn't work. That can't be. That's a poor medicine, and that's honestly, that's a definition of malpractice to do something like that. Errors, mistakes in medicine happen, but they have to genuinely happen because patient's disease, it's a complicated patient or something like that. They should not happen because of the negligence or lack of time. Those are not excuses that I think that any of us can live with. So looking at this basically intake from the patient, we haven't even asked them about any emotional components of their lives. And that's why I'm so blessed to be part of functional medicine community, where I actually can see a patient with a problem, with new patient. We schedule them for 60 minutes. And honestly, sometimes even that is not enough. But usually by the end of an hour, most people feel heard. Even maybe we didn't discuss every aspect of their lives, but they're heard. Somebody listened to them. Somebody is trying to understand. And all these emotional questions, all the tangents that I listed that maybe they feel like they're extra. They're actually not extra. In the context, everything matters. So if, let's say, every time a certain friend visits you, you start having stomach pains, what does it mean? What does it say about your relation? Maybe this person is toxic for you, like literally toxic for you, because they're triggering your IBS, another condition that's basically not a real condition because it's a component of multiple issues that are called IBS. There are tons of types of IBS that we see in our clinic, and that's why I kind of don't even believe in that term anymore. I think that each of them should be named separately, but we have no names for that. So everything matters. Your emotional condition, feelings, your spirituality, everything makes you you, and it affects your health. So the health is truly needs to be holistic. It has to be a whole. So I want to come back to an earlier point that I made, is that does every appointment need to be, let's say, 30 minutes? Because I'm actually proposing 30-minute appointment. Then actually, no, every appointment doesn't, because some follow-ups could be very easy. Or, for example, a very easy 5-minute appointment if somebody comes in for suture removal. Sutures are removed, and I communicate to the patient that something is benign. That only works if something is benign. If it's cancerous, obviously, it's not 5 minutes. If it's something benign, we're done. Patient is happy. They're healing well. Whatever we removed was benign. The end of the story. Great. Or another situation where, let's say, patient comes in with something that came up on somewhere on their skin in the last few weeks, and they're so worried that it's a cancer, it's something bad, and they can't sleep. So they bring just one concern like this, and I reassure them because it's totally benign. And in that's a very short visit. It's very satisfying for both of us. There's no need for extra because it's not that type of a visit, but it's a great visit. So that's why not everything is the same. No, not every patient encounter has to be 30 minutes. However, we do have to have that freedom of seeing patients for 30 minutes, because if the doctor is seeing 40, 50 patients a day, that's not normal. That's not normal. How does insurance work with that? Insurances do not like doctors who habitually take their time, and they do allow longer visits in some circumstances, and you have to document that it's a complex patient. Or again, in cancer diagnosis, sort of first visit about the plan of what we're going to do about this newly diagnosed cancer, and some other situations in different specialties. It is allowed. However, if you start habitually seeing patients for 30 minutes, then you're going to be basically reprimanded because you will be told that you're not utilizing your time efficiently compared to your peers. And that, of course, is a very concerning thing to hear from the insurances, be it you're in your private practice, or especially if you work for the hospital for a bigger practice, where you basically, as a doctor, you're basically told what to do, unfortunately. And that's very, very sad. So I think that we should ask, we should demand, and I think that we should hope for 30-minute visits for many medical issues and possibilities. And I'm not obviously going to list all of them here. And I do think actually that there's so many positives. The positives are increased patient satisfaction, decreased provider burnout, but also with all of this, better care. There's just better care and less medical errors. That's extremely important. From the negatives, I don't see many negatives because there's still going to be some shorter appointments. And even for reimbursement for insurances, it's probably going to be not significantly different reimbursement because now there will be less patients for the insurance. So they will pay more for existing patients. So instead of paying for 40 patients, they will pay, let's say, for 25 patients, which is still a lot, of course. It's just still very high numbers. To see 25 patients a day, it's hard as well. So that brings me to one negative that actually I don't really think it's a negative again, but it is an important point to make. So if the doctor who used to be seeing 40 to 50 patients a day now is seeing 20 patients a day, for example, that will mean that the access to medical care is decreasing. And in some parts of the country, that is already the case when people have decreased access to medical care. They have to wait for months to see the doctor. Of course, that's not good. But then ask yourself, what would you prefer, quality or quantity? And honestly, when it comes to medical care, which is our survival of our body, of our brain, of our whole being, I honestly think that quality matters the most. Thank you so much for watching. I'm looking forward to reading your comments, what you think about this very, very frustrating issue. And of course, please like, share, and subscribe. Thank you so much. Until next time. Bye-bye.